I'd like to introduce you now to Michael Dowling. You've heard him speak just a little while ago. He's President and Chief Executive of Northwell Health, New York in the USA. He's one of healthcare's most influential voices, and as President and CEO of Northwell Health, he leads a clinical, academic and research enterprise with a workforce of nearly 80,000 staff and an annual revenue of $15 billion. Northwell Health is the largest healthcare provider and private employer in New York State. Northwell also pursues pioneering research and a visionary approach to medical education, highlighted by the Zucker School of Medicine, and has one of the nation's largest medical residency and fellowship programs. Michael Dowling's leadership has been invaluable to Northwell's consistent expansion and prominence. He has served in New York State government for 12 years, including 7 years as State Director of Health, Education and Human Services and Deputy Secretary to the Governor. Before his public service career, Michael Dowling was a Professor of Social Policy and Assistant Dean at the Fordham University Graduate School of Social Services and Director of the Fordham campus in Westchester County. He grew up in Limerick and earned his undergraduate degree from University College Cork and his master's degree from Fordham University in New York City. A Harza. Could he give false war with Michael Dowling?
Good morning again, and I'm delighted to be here. And so let me begin by saying that this is an unbelievably exciting time to be in healthcare and to be in a leadership role in healthcare. In fact, for that matter, it's an exciting time to be in a leadership role in any business because there are major transformational changes occurring all around us. The ground underneath us all is changing continuously. And of course, we are all affected by what has occurred over the last 3 years. And there are lessons that we've all learned over the last 3 years that obviously, if we're smart, we will take advantage of those lessons to help us as we go forward. So in many ways, it's a test of leadership now for universities, for healthcare organizations, and for that matter, for every business, because it's an opportunity now for all of us to think very differently. In my view, we're at a pivot stage. We have to challenge the status quo. We have to understand, as I told people last night, that nostalgia is not a strategy. Just believing what occurred in the past is not good enough to help you go forward in the future. So it's an opportunity now for everybody to create a little bit of disruption. You've got to shake things up if you want to make progress. You've got to be able to take risk. Just doing what you did yesterday is not good enough. And of course, as you all know, when you take risk, you're going to actually upset some people. But I'm a big believer, if you're in a leadership role right now, when you don't upset anybody, means you're not doing anything. You're standing completely still. And that applies to healthcare in a big way, in this country and actually in the United States. In the United States, there is no one model of healthcare in the United States. It varies depending on where you are. I happen to be very fortunate to be in New York and to be the biggest provider of healthcare in New York State, starting with one hospital many years ago, and now being the largest player. And that created some disruption. Necessary, but we have to continue to disrupt anew again. So I will also say at the very beginning here that we have an opportunity for partnership between Northwell and the university and between Northwell and the delivery system in this region. I think there's many things that we did together in the past. Over many years, I've been over here a number of times with CELTA, and I think that we can continue to do that going forward. So I make the offer that we're always interested in partnering and working together, because the more we work together, the more we learn from one another, and the more everybody will improve. So what I'm going to do for the next period of time, I'll try to stick with the schedule. I know we're running a little bit behind schedule, so I'm going to try to do this relatively quickly, is I'm going to, since I was asked to talk about the future of healthcare, I'm going to take what I consider a balcony view. It's very important sometimes to stand back from the day-to-day, kind of go up on the balcony and look down on the business and ask yourself the question, what do I see? If you're very close to the action, sometimes you don't see what's happening. It's like if you go to a sports game and if you stand back from the play, you can see the play is about to occur. When you're right up close, you see the action in front of you, but you don't see the plays developing at a distance. So we take the balcony view, and I'm obviously influenced in a big way by my experience in New York, but also influenced by my involvement in Ireland off and on. Over the last number of years, I've been on a number of the commissions on healthcare reform here. And I have to say, a little bit frustrating, to be honest, but that's the way life is, of course, at times. So I'm going to take the balcony view, and I'm going to mention 10 items. Each one of them has major implications for the delivery of healthcare, but also has major implications for education. Because if education doesn't change, we're not going to create the workforce that we need in the future to change care delivery. And if care delivery doesn't change, we're not going to be in the future able to provide the care to the public that we should be providing and that we are accountable for. Now, David Thoreau had a wonderful statement, which I like very much. He said, you know, it's not what you look at that matters, it's what you see. So as you look at things, ask yourself the question, what am I really seeing? What are the trends? What's happening? What's different? How do I create that difference? So I'm going to talk about 10 things. And each one of them, by the way, you could take hours to discuss each one of these. Each one of them could consume an afternoon. There's multiple detail behind each. Obviously, I can't do that, so I'll kind of do it very generically. But if you think about it, you'll begin to see the implications. The first item for me, and I'm now coming at it as a provider of healthcare, and as was mentioned in the introduction, we're a $16 billion business. Right now, we have 81,000 employees as of last week. We have a massive delivery system with huge academic teaching place, huge research, et cetera, medical school, nursing schools, et cetera. So the first item for all of us is that we have to be fanatical about customer and patient service. And I use the word customer because I believe patients are customers. They have choices, or at least they should have choices. The customer today, the patient family today, and I include patients, families, visitors in all of this because that's who we take care of. That's who we see. So if you look at it from a customer point of view, it changes the way you think about it. And today's consumer is very different. They're more educated, more knowledgeable, more technology savvy. For all of us who are the baby boom generation in leadership, think of the young people, think of your kids and how they operate each and every day. And think about how it is they're going to operate in the field of healthcare in the future. How they want things, when they want them, where they want them, what mechanisms and processes they need to go through to get it. We have to be very, very conscious of this. So your relationship with a patient/customer in the future, it's not a transaction. We've always been involved in the transaction issue. I see you, take care of you, you're gone. You're now developing the concept of relationship with a patient-customer. So if you think of that, it changes the way you also view things. And it means that you spend an awful lot of time thinking about convenience and access. I'm baffled, I have to say, and I'm known for being a little bit blunt, I'm baffled by the access problems here in Ireland. There should not be a wait list. You should have a concept, there is no wait list. It's access, it's convenience. Think of it not from the inside out, think of it from the outside in. As a provider, traditionally would say, what's good for us? What's good for the docs? What's good for the nurse? What's good for the organization? That's not the question. The question is what's good for the consumer? From the outside in. How do they perceive it? We are here because they're there, not the other way around. So access, convenience is going to be very important. Location of care. We should be taking care to where the customers are, rather than making sure that the customers come to care. Now, maybe explain this a little bit. There is no reason as a delivery system you can move care out to where people exist. Decentralize. No need to bring everybody into the middle. I'll explain a little bit more of that in a second. And of course, patients, consumers in the future are partners in care. You have to work with them to help them to make decisions about what's good for their own health, and you'll be a participant with them in improving their health. So location of care. Why, for example, should everything be done in Dublin? Why should you be going to Dublin for basic care that can be provided increasingly more locally, especially specialized care? You should not have to travel 3 hours to get basic intensive care that you need, which can more appropriately be done locally. What we've done in New York is I've taken open heart surgery that was in one of our central hospitals, and I moved open heart surgery out into the community hours away so people don't have to travel to get it. Consumer focused. I serve you, not that you just have to accommodate me. That's not the focus. So, as you do education, training, and you look at it through the consumer lens, patient, family, friends lens, think about how you educate. That's number one. The second point I want to make is that optimum care is a continuum. The hospital is only one part of the continuum of care. The hospital is not as centric anymore as it used to be. The continuum of care is primary care, outpatient ambulatory care, inpatient care, home care, post-acute, digital care. It's that full continuum. Whereas in New York, I have 23 hospitals, but I have 870 outpatient ambulatory locations. 95% of cancer is non-hospital, it's outpatient. Surgery is moving outpatient. I dare say that within 5 years, almost all orthopedic surgery, except for major spine, will be outpatient. If you're in our system today and you need shoulder replacement, you need hip, you go in the morning, you're seen at 7 o'clock, you're in the operating theater at 8 o'clock, and you go home at 3 o'clock. It's moving out. Cancer, imaging, diagnostic and treatment, increasing surgery. Now, I know there are people, probably people in the room saying, oh, no, this doesn't happen. Yes, it does. That's the way it's going. The hospital is not the center of the universe anymore, but that does not mean that hospitals are not important. Hospitals are very important. They are the best places to be when you have to be there, but they are the terrible places to be if you don't need to be there. You move care out into the community close to where the consumer is. It's better quality, better service, better access, better convenience, more appropriate. And of course, the digital aspect of care is going to be dramatically enhanced. I believe that in the next number of years, the first interaction with a physician or a nurse or a practitioner, however you define it, is going to be digital. And home care, we have massive home care. We are now providing hospital care in the home. What was once hospital care is in the home. The transition from inpatient to outpatient is huge, and the transition from inpatient to home is huge. And that trend is continuing. We're building up home care, building up ambulatory. I believe that hospital care in the future will be primarily places where babies are born and intensive care, ICU care. That's what a hospital is. You have basic stuff that can be taken care of on the outside, should never be going into a hospital. And unless you build an ambulatory network, you are never, ever going to reduce your wait list. You're going to always have an overcrowding issue all over the place because you're bringing things, a lot of services into a hospital that shouldn't be coming into the hospital at all. That means thinking a little differently. Our third point, question then is, how do you organize this? Well, I'm a big, big fan, and I think there's a great opportunity here, and you've got a very good local delivery system here with CELTA, which I've been involved in to some extent, to create these regional integrated health systems, which includes all of the components. Inside an integrated system, you should have the inpatient, the outpatient, the home, the post-acute, all together. And they should be all under single leadership, singular auspice, singular governance. So in my organization, and this is the way it's moving in the United States, I have hospitals, I have ambulatory, I have home, I have post-acute, I've got assisted living, I've got digital, all together, all integrated. No separate silos. I've got my own transportation company, I got my own purchasing company, I got my own lab business, my own pharmacy business, all together. You can't have these in silos where you control hospitals and somebody else controls primary and somebody else controls ambulatory. Remember, from the customer point of view, it's managing the continuum. It's managing the transitions of care. Because people go from inpatient to outpatient to primary, especially as we go into the demographic changes in the population, it's the continuum. It's how all of the pieces are interconnected. That's how you got to be thinking about it, not hospital care. And I've been saying in many of the entities I've been involved in here, stop talking about hospital systems. Talk about integrated delivery systems, which is all the components. And that's point number 3. Point number 4 is that we have to continue to optimize the use of technology to enhance performance. Administrative performance, clinical performance, and research performance. But I won't belabor this point too much, but I will say this, that we have to be very careful. Technology is a wonderful tool. We're very, very involved, as I know many of you are in this room, on AI and all of the technology enhancements that have a wonderful potential to change a lot of what it is we do. But we have to never forget the human element in care delivery. It's a combination, it's a balance between the technology and the human aspect of care delivery that we have to be very, very, very careful about. And that's something educational programs and people who do the teaching have to be very, very careful that it's not just only about the technology. You have to find that beautiful balance between the technology and the human aspect. If you go too far one way and you don't maintain that balance, you and I believe are going to have a severe, severe issue. And let me go back to one last thing I mentioned about integration a second ago, about these integrated systems. Integration is also about the doctor, the nurse, and the administrators working closely together as an integrated team all the time. This is not about physicians in one silo, nurses in another silo, administrators in another silo, rehab and PT in another silo. That does not work. We're all one. It's a team. It's like a sports team. All integrated, all working together. In our system also, for example, we have, multiple emergency departments. And by the way, I will say, we have 60 urgent care centers. These are 60 mini emergency departments out all over the community to decant away from the emergency rooms. These are ambulatory. So to try to avoid people going to the emergency rooms, you actually create new locations out into the community where people go for basic stuff so they don't have to go to the hospital. That's part of the integration effort. And then we work along service lines. So if my head of emergency medicine oversees emergency medicine everywhere across the whole health system, inside and out. My head of medicine oversees medicine everywhere, inpatient, outpatient, and the home across the continuum. So integration has many, many aspects, and we could spend an awful lot of time talking about it, but it's all about team, working together closely. And education has to force the team approach, the interdisciplinary approach. So it's not, and that's true whether or not you're in the medical school, in the nursing school, it's about bringing things together and teaching interdisciplinary. Patients / customers, you come to the hospital and you have an orthopedic problem. If you're an elderly person, you also probably have a cardiac problem. You not only have the musculoskeletal issue, there is probably in some cases a mental health issue. All embodied inside the person. I, for example, have had multiple orthopedic surgeries. But I also had 3 stents because I have a cardiac issue. So when I go to the hospital or the ambulatory place where I go for surgery when I've had my shoulders done and else, I don't go to the hospital, but I need the cardiologist along with the orthopedic guy working with me. It's not just the orthopedic guy, it's the cardiologist with the orthopedist. And the coagulation person because of the possibility of clotting. Team. So let me mention another issue, I think number 6. The future requires a massive transformative investment in human capital. And this is something that delivery systems can do along with and in partnership with education. So what you're trying to create in an organization, what I try to create, is a culture of collaboration and a culture also of innovation and continuous learning. And this gets to a number of aspects of this. One is how you recruit. Right now, for example, I recruit 300 new employees a week. And I personally meet with all of those employees every Monday and have been doing it for 21 years. I meet all new employees because who you bring into the organization determines the future of your organization. If you don't bring in the right people, you've got a problem. So you have to have strong criteria for the types of people you want. It is not just the people with the credentials, it's the people with the attitude, the perspective, the compassion, the caring, the dedication, the resilience. It's you want optimistic people. This also applies to how do you pick your leadership. Remember, people want to work, they don't want to just work for an organization, they want to belong to a cause. They want to belong. You want to create that sense of belonging among the staff. When people leave an organization, they don't leave the organization, they leave the supervisor. So who's your supervisor? Not the person necessarily with the credential. Does the person have the ability to influence behavior? Does the person have leadership ability? Is the person willing to move forward? So you've got to spend a lot of time creating this kind of a culture. And education, in its educational programs, have an opportunity to build that from the very beginning. To not just only be about the credential. We should be enhancing apprenticeship programs. So you teach people how to do things. For example, our medical school, And the trouble with this is that there's so many aspects to this that you could spend forever talking about it. In our medical school, all medical students are trained as EMTs in the first 9 weeks. They all ride our ambulances. They're all out in the field. They see patients from day one. They go to people's homes. They're out in all of our ambulatory sites. They're not sitting in classrooms. We don't have lectures. We don't have multiple choice exams. We test using simulation and small group sessions. It's learning by doing. You take students and you put them in to go to a person's home right early in their training. It changes their whole perspective of the kind of the world that they're in. You have them out in our ambulatory sites all over the place. Of course, we have the benefit of having almost 900 of those. They learn by doing. And when we started doing this 13 years ago in our medical school, everybody told us that there was no way that this could succeed. It wouldn't work. They wouldn't pass the exams. They'd blow the exams out of the water. They match in the top places in the United States. A phenomenal success. So yes, change is possible. Things can be done very, 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 very differently. And you also, among your staff in your organization, and I know Pat and we talked a little bit about this in the past, you've got to provide the opportunity for staff to innovate, to create risk, to come up with new ideas. You know, over-regulation and compliance are the antithesis of innovation. So you should be fighting bureaucracy all the time. If there's a rule book for something, you should start by saying, maybe I should get rid of the stupid rule book. Because the rule book was built for yesterday, remember? It is not built for tomorrow. Now, some people are very resistant to do this, but I like to challenge these things all the time. Why did you create a stupid rule book that is built for something that was done 10 years ago that has no relevance to the world that we live in today? That is not consistent with the desire to enhance the consumer service or the access to patients out there today, very different than before. So you got a challenge. So what I did years ago, and what we have inside our organization, and some people from here have been over there, we created a Center for Learning and Innovation, which is my in-house corporate university. So I create an awful lot of my own training programs. So I have leadership training programs, middle management leadership training programs, et cetera, et cetera. The list goes on and on. I have a complete course curriculum. And like I said to some people from here last night when we were at dinner, I work with universities all over New York, but if they don't move fast enough to change, I am creating my own educational programs. I'm not waiting around for a local university to take 5 years to develop a program to help me find the skill that I now need tomorrow, not 5 years from now, because the world is changing very, very fast. So I've said to the universities, I work with you, partner with you, but if you don't do it, I'm doing it. And believe me, it's going to happen here where we're all going to have a lot more competition than we think about. Even though the Irish situation is different than the American situation, but don't assume that there's not going to be other organizations coming in as competitors to challenge what you do, which forces you to think quite differently. I now have to compete in New York with Amazon, with Google, with private equity companies, with local pharmacy chains, CVS, big pharmacy chain that owns a big insurance company in the United States. They are now all competitors. So I don't innovate quickly, I am dead. Because it's quite competitive. And I also would say one of the things that needs to be done in Ireland is we need to build some competition into the system, because if you don't have competition, you just get fat and lazy. You just sit around because nobody competes. It's like if you play sports. I played with Limerick one time, years ago. You train when you know you're going to play against a good player. If there is no good players that you play against, what the hell do I need to train for? So competition instills that desire and that grit and that determination. I'm a big fan of competition. Each hospital in this region and around the country should be competing with each other on outcomes and metrics. And there should be a penalty for not being able to hit the targets. If there's no penalty, why care? Why strive hard? In our system, and there's lots wrong with the United States system. I'm not suggesting that we're perfect, but I believe we've created a pretty good thing. But if I don't compete well, and I don't serve the public well, and I don't innovate, and I don't provide the right environment for staff, my competitors win. So I can't stay still. And you're forced to think each and every day how to do something uniquely. Next point I make, and each of them, as I said, could take a much longer period than I'm giving them. Care delivery focus. I'm not going into the issue of clinical care and the variability that exists, et cetera, but there are areas that we have to focus an awful lot more on. One is, for example, chronic care illness management, how we manage chronic care, how we train people to figure out how to provide comprehensive care management to chronic care patients in the home, on the ambulatory side, on the inpatient side. How we deal with women's health, big issue. We've always followed the model of male health. Most research has been done on males, not on females. And most of the focus on women has been, as they call, the bikini focus. But it's very different now. So we have a major effort on women's health. Women are the drivers of healthcare delivery, of healthcare access. We all go to the doctor, if you're a male, because the female in our lives pushes continuously to do so. I go to the doctor regularly just to keep my wife quiet. Otherwise, I don't have domestic bliss. Okay? I say, I'm going, please, I'm going. Leave me alone, I'm going tomorrow. But we have a major women's health initiative focused on women's research, focused on women's cardiac care. And the other issue that we've got to spend an awful lot of time on, and this goes back into how we educate as well, is on behavioral health. Behavioral health, to me, is one of the areas that is going to cause the biggest problem for us. It is huge, growing phenomenally, especially among adolescents. So women's health, chronic care management, behavioral health as major foci for both education and focus on the delivery side. And a couple of other items. Another balcony view point that I want to make is that we have to be thinking about going upstream. Medical care, the medical aspect of care, is only a small component of health. Medical care delivery is not the equivalent of health. 80% of people's ill health is due to lifestyle, behavior, and social circumstance. It's what people do to themselves. It's smoking, nutrition, exercise, living in a bad neighborhood, being in an area with poor public health. That's what drives most illness. We deal with the medical care aspect of it. If we're involved in health, we got to be involved in a lot more than just the medical aspects of it. Food. We got to spend an awful lot more time on the issue of food. And my hospitals right now, all of food service is provided by Michelin star chefs. People want to come to the hospitals to eat. I'm thinking of opening a restaurant, by the way. This is the craziest thing in the world. I spent years getting complaints about food. Now I get letters thinking, oh my God, the food was fantastic. I said, well, was the doctor okay? Yeah, the doctor was all right, but the food was great. I'm coming back. The food was terrific. Food is health. So from an educational point of view, when you're thinking about how you educate, it's another component. What we do with schools. We're very involved in our organization in providing continuing support to high schools, opening up avenues. I'm sure you're doing this here, opening up avenues for high school students, showing them the careers that exist in healthcare, mentoring, coaching, bringing them in under hundreds and hundreds of apprenticeships that we do with students. This year, for poor students and poor families, especially minority families in the area of New York, we are working with hundreds and hundreds of students, and if they make it and get accepted to college, I will pay tuition. The health system will pay tuition. That's health. I take a kid out of a poor family, I give the opportunity for them to go to college, I'm improving the health of the family. I'm opening up opportunity, it's health. So we got to think about health differently. We got to redefine it. What is it? The whole issue of public health is huge. So we got to get beyond just a traditional medical care delivery system to be broadening our definition of what health is overall. And I will mention one other area that will hopefully make the point. It doesn't apply here. Fortunately, you're lucky. And this is the issue of gun violence. Gun violence is a public health issue. We've taken the lead in the United States on the gun violence issue. I've created a national coalition. I've created a Center for Gun Violence Prevention inside our organization. Gun violence in the United States, the leading cause of death among kids in the United States is guns. For kids and adolescents, the leading cause of death is guns. The second cause of death is automobile accidents, and the third cause of death is cancer. The leading cause of death is death from guns. Our children's hospital, we got psychiatric hospitals, we got a children's hospital, a very famous children's hospital. We've had more kids in our hospital so far this year resulting from serious gun violence than we've had cumulatively in the last 5 years together. It says something about the toxicity of the political system in the United States, but it's a health issue. And because I took on this issue, and also because of issues we took on regarding COVID, mandating that you cannot work at Northwell unless you're vaccinated, I've had to have security at my house round the clock for months because of death threats. But you take risk. You want to move the agenda downfield? There are cops saying, I'm here now. There are police in my driveway to make sure my wife is okay while I'm here. But that's, fortunately, not your issue here. But the point I want to make is, it's an issue over there, but it's a public health issue. It's a health issue. It's just not a gun issue. So as we educate students and as we look at what we do in the care delivery side of the world, think of what you mean by health. Like providing opportunities to kids from high school to go into the field of healthcare is health. And you know what I tell students all the time, it doesn't matter what you want to engage in as a specialty, we've got it. You want to be in finance, we got a finance department. You want to be in technology, we got a technology department. You want to be in the food business, we provide 50,000 meals a day. You want to be in the construction business, I do $1 billion worth of construction a year. You want to be in the real estate business, we got the real estate business. It's just not the doctor and the nurse. My point is that we got to think more globally. The possibilities that we in the healthcare field have to change the nature of what society looks like is extraordinary, more so than most others. A major, major obligation. And of course, I could talk about, which I won't go into here, in our situation, we spend an awful lot of time on infrastructure improvement, how we build buildings, how we build hospitals today, our ambulatory sites today, different from the way they were done before. So how do you build a building that is much more technology savvy today, but also much more consumer savvy? How does the consumer look at the building? So last week, before I came here, I did a groundbreaking for a 15-story new building in the middle of Manhattan, which is cancer. Outpatient, ambulatory, because all cancer is outpatient. You shouldn't be treating a lot of it in the hospital at all anymore. Most of ours is outpatient. And that building in Manhattan, the question we have been working on is, how do we design that building to be unbelievably consumer-friendly? Thinking of the consumer of the future. And the other thing, of course, is that we're very involved in is creating new businesses, starting new businesses. We have the ability in New York, of course, to do this, and health system. I have my own pharmacy business, my own supply chain business, et cetera, et cetera. So I can, if there's something I see that is a bad need, I have the ability to do it. You're a little bit more constrained here because of sometimes over-regulation by the HSE and over-regulation coming out of Dublin. You see something here in the West that should be done differently, I would take the risk of going out there and saying, I'm doing it differently, to hell with the national rules. All right? I know the strategic plan that was written basically states that it has to be consistent, or it should be consistent with national policy. Why? If the national policy makes no sense, if you think it makes no sense, why comply? Force the change. Rules are meant to be broken. Right? You have to be relevant tomorrow, not yesterday. So I'll conclude with a couple of comments. One is, a key to the future, in my view, is having the freedom to innovate, do things uniquely, and fight bureaucracy. The future depends in a big way, in my view, about creating elements of competition among our delivery sites. If you got 5 hospitals in Salta, develop a dashboard of metrics where they have to compete against each other. Because if there isn't any such competition, you have complacency. You need to decentralize care. There should not be building a massive new hospital in Dublin. There should be spending time developing local delivery sites in the western region, the southern region, whatever regions you may want to pick on, moving care out. If I have a sick kid, I don't want to spend 3 hours driving to Dublin for something that can be done locally. If I did that in my system in New York, I would be dead in the water because my competition would be ahead of me. Right? And I would say, take risk, challenge. The opportunity that we have to do something different is unbelievable. But that's what leadership is about. Leadership is about leading from the front, as well as leading from the rear. It's about influencing behavior. It's about taking the hits. It's about not going along when going along is the wrong way to go. It's to be excited. It's to be upbeat. It's to be optimistic. One person asked me last night, what kind of person do I look for to take on any leadership role in my organization? Or for that matter, any role? I look for positive attitude. I look for people where the light bulb is 100 watt. People who are excited, who care, who want to be here, who want to change, who have a high tolerance for discomfort, right? Who want to be innovative, who want to shake things up, who want to compete, who have resilience, who have a high degree of curiosity, where they're constantly trying to figure out, how do I learn more about how to do things better? Those are the kinds of people you get around you. And you always prove you're smarter when you hire people smarter than you. Right? And it's about team. It's not about the old 1950s, command and control. It's about team. It's about the doctors and the nurses and the administrators working together in total concert. It's not about the doctor being the king and everybody else follows behind. That day is gone. That day is irrelevant. It was never relevant. It's about lighting a fire in people instead of lighting a fire under them. It's about getting people excited. So I would say to you, get excited about what you do, shake things up. The public needs it, the public wants it, and be unbelievably consumer-centric. We exist because of the consumer that needs us. That's what we do. So I could go on and talk for a long time about this stuff. I'm excited about it. The opportunities are just phenomenal. I get up in the morning, I cannot wait to get to work. So enjoy, guys. Thank you so much.
Future that starts here.
Michael Dowling, wow. What an absolutely fascinating insight into Northwell Health. We obviously have an awful lot to learn from you. Now, this is going to inspire a lot of questions, I'd say, from the audience. Oh, yes, please, please state your name and your question for Michael Dowling, please. Thank you.
I'm a Clare man and I have a particular antipathy to Limerick people, but I get over it sometimes. I'm inspired every time I hear you speak. There's a couple of things I want to say. I want to set you a challenge, right? This time last year, on the National Development Plan, we managed to get a cancer centre for Celta along the lines that you said, with a cancer network across the region built in with appropriate infrastructure. Since then, I have been trying desperately to get it advanced, right? And I'm challenged, as with Pat and Tony Canavan and Chris Kane, everybody that's involved in trying to move the strategy on for infrastructure in our institution. So I want to get you some, I want to put two questions to you, right? One is, could I get some help from your innovation department in terms of how we get this moved on, right, overall? And secondly, in the context of staffing, which is a challenge across the world at the moment, can you give me some semblance of the numbers of people in your organization that are homegrown versus the numbers that you bring in from all over the world?
On the first question, the answer in terms of providing some advice or help to the extent that we can, absolutely yes. I've spoken to Martin last night and others about that. I'd be very willing to have some of my people come over here in December or January to meet here. It's good for them because they learn and they get educated the more they do that, but also to provide some, tell you what we're doing to see what can be applicable, because everything is a little bit different. You can't do things here exactly the way we do them over there, but there can be advice that would be helpful. So the answer to that is yes. On staff, on regular staff that we hire, like we hire 300 people a week, as I mentioned, they're all pretty much local. We did take a little bit of a hit because of COVID, and we were the epicenter of COVID. We had more COVID patients at Northwell than any other single entity in the United States. We treated 450,000 COVID patients. We had 4,000 COVID patients in our hospitals on a daily basis. We were the center. And because I required that all employees had to get vaccinated, no exceptions, I lost 1,800 people, which is okay. I believe that if you don't comply with the requirement of employment, you don't work here. And that was our philosophy. So we're doing a little bit of catch-up. But all of the local employees are pretty much, all of the regular employees come pretty much locally. On leadership, I go outside, I would say, for maybe 15% of the time. Less so now than I did years ago. Years ago when I was building the system, because I started with one hospital, when I was building the system, I went outside a lot because I had to get rid of a lot of the people we had. And, you know, it's a lot easier, as a phrase I've used to people many times, I said it's a lot easier to change people than to change people. So, so if you're trying to change a person's behavior, they can't change, they don't go with the program, then you get them out, you change them. And you can't be afraid to do this. So years ago, we brought in a lot from the outside. Today, less so. Recently, I got my chair of neurosurgery from Hopkins, my chair of medicine from New York Hospital, my chair of orthopedics recently came from special surgery. We're growing now for a number of my other clinical leaders. We're growing them inside because I got leadership training programs. So there will be a leader in OB, women's health soon that will be from the inside. On the outside, when I wanted to focus on access, convenience, and service, customer service, I brought in an executive from Ritz-Carlton. He was a person that ran Ritz-Carlton hotels all over the world. He now runs. When I wanted to do the food service improvement, I brought in a Michelin star chef. He had been the chief chef at the Plaza Hotel for years. He's now my chief chef. He brought in 4 other Michelin star chefs. So I would say about 10 to 15% is now coming in from the outside, but I'm very selective. I spend most of my time building from within, retraining, building from within, because I have to maintain the culture. It's not about bringing in a person to fill a slot. I have to add and support the culture, which is collaborative teamwork. And when we bring somebody in from outside, especially in the clinical leadership position, I put in an MBA or a process engineer next to them all the time to get them to understand what the culture is like, how to manipulate across the whole healthcare system, how to influence behavior. It's not what you control that matters, it's what you influence that matters. So I hope I answered your question, but about 15% from outside.
Very good, thank you. Yeah, get the microphone. Thank you.
Thanks, Michael. Fascinating, riveting talk. Declan Devan, School of Nursing and Midwifery. You had given some anecdotes about how you identify leadership within your organization and some of the, what I thought were quite novel approaches, maybe sitting at the back of rooms. Perhaps you might want to recount some of that?
Yeah. Well, first of all, let me take the hospital side for the second. We've got 23 hospitals. You've got 6 tertiary campuses, 1 quaternary campus, community hospitals, psych hospitals, children's hospital. None of my hospital administrators that currently run these places ever before ran a hospital. If you came to me with a CV and said I had been running a hospital for 20 years, I wouldn't hire you. Because I would get a hospital of 20 years ago. So I look for how I pick those people. We all of these are trained from within, pretty much. I have succession planning everywhere, so I know who can replace everybody in every part of the organization, and everybody knows. The people who run the facility, they know who could possibly replace them. I look for attitude, ability to influence. I've said it before, ability to influence, positive attitude. People who look at something and say, that doesn't look right, we got to shake this up. My head of human resources was a PA. Now this is something, by the way, that you're beginning here, I believe, but physician assistant as a role is huge. All of our surgeons have physician assistants. This is why you enhance dramatically the productivity of a surgeon when you have physician assistants. But the physician, we had this physician assistant, he was in the cardiothoracic area, in the operating rooms, very, very smart, very outgoing, and like shake it up type of attitude. I took him out and I put him in charge of some ambulatory programs. And then he used to always complain to me about HR. HR, oh, it sucks. I said, okay. So we had breakfast. I said, so you think HR sucks? Yeah, it's terrible. I said, okay, you're now head of HR. So he became head of HR. Fantastic. I still have promoted more. The fact that he didn't have an HR background, I could care less. I was more interested, what can you do? Or you're interested in moving things forward. And HR it's all about talent management. A good HR person enhances the talent in your organization. It's not about transactions, payroll and pay slips and all of that kind of stuff. That's all back office function stuff that you can do. It's not unimportant, but that's not the key. So I have a cadre right now of about 350 people. I have a book on each of them from across the organization. I know everything about these people. We coach them, we monitor them, I have lunch with them, we have breakfast with them, I move them around the organization and eventually find the right spot for them. They're mostly all, and go back to the previous question, all homegrown. But attitude, attitude, attitude. Ability to work across departments, across disciplines. And I could care less what school they went to. I don't know, doesn't matter. You have a degree, great. What's your grade point average? I don't care. I'm interested. What can you do? What can you do? This is why education and apprenticeship should be enhanced dramatically. I'll give you one last example, then I know I'm running way over. I worked as a plumber one time. I started out as a longshoreman in Manhattan, in New York, and then I worked in construction for years, and then I became a plumber. And I could get a book and read about, and I used this example last night, about how you put a sink in. But you know, you have no clue about how to put a sink in until you put a sink in. The book doesn't tell you. You know, you have the intellectual know-how a little bit, you gotta know what tools you use, but doing stuff makes all the difference in the world. So if I have an administrator that I think has a future potential, I put him as number 2 in a hospital, I see how they work as a number 2, and then I move them up to number 1. But attitude, optimism, resilience, etc. Can you handle, everybody can handle the good times. Can you handle it when life sucks? Right, and I'm being blunt. So during COVID, I was always, during COVID I said, this is not the worst thing that people ever experienced. It's not what happens to you in life that matters, it's how you react to it. You don't freak out, you stay calm, right? You handle the circumstance, it's right in front of you. You don't run away from it, you don't admire it, you don't whine about it, you don't complain about it, you do something about it. That's the kind of person I want.
Michael, do you have anything like the HSE in the United States?
Given the current configuration, if you asked me to take that job, I would probably shoot myself first. No, I mean, let's be blunt. I've said it publicly. You know, you've got to blow up the bureaucracy to promote innovation.
Is there some kind of bureaucracy in the States, you know, laying down, you know, rules and regulations?
But you regionally here can begin to shake things up a bit. We get regulated in the United States. I have the state, I have the feds, not like here. But I challenged the Joint Commission, which is in New York, well, you're familiar with it probably, comes in and reviews all healthcare. And a couple of years ago, they came in, they had this stupid process of analyzing and monitoring employee talent and performance. It was the stupidest thing I'd ever seen in my life. Had no relevance to what went on the day-to-day at all. And we're in a meeting like this, big meeting like this, the Joint Commission was there. We had gone through a multi-week review for us, and they were complaining about this thing. I mean, the fact that our performance management system wasn't right. I get up to the microphone, my staff almost had a heart attack, but I get up to the staff microphone, and I got so mad, I said, let me be clear, the Joint Commission, and they review us, they could kill us. I said, let me be very clear, I'm not doing that stupid stuff anymore. If you can explain to me the relevance of that stupid rule to what goes on at the day-to-day anymore, I may give in, but you can't prove it because it makes no sense. So I'm not doing this anymore. This is a real case example. I'm not making this up. I said, I'm going to design a new performance mechanism, and you're going to approve mine. The guy said, oh my God, how could you do that? I said, I'm telling you I'm doing it. I'm not complying. because it is so stupid. I'm wasting days and months with all of this regulatory crap, filling out documents all over the place that nobody cares about, frustrating everybody. So I came up with our own. 2 years later, they approved it. Fine. Why not? You know, why not? Yeah, but be willing to take some of the hits from people, and if you take hits from about doing the right thing, you're taking hits from people who don't understand, who don't know what's going on the ground.
Any more questions for Michael Dowling? Michael will be actually staying with us for the duration now, so we'll be able to ask you loads of questions again when you hear about the different aspects of health services here. Yeah.
Let me just conclude with this thought. I've been very impressed by the staff here. I've spent time talking to staff, not just here, but in other parts of the Irish health system. I'm impressed with the physicians. I'm impressed with the nurses. I've spent a lot of time talking to nurses. Wonderful, wonderful people doing great work. But they need the freedom to do more. And you've got to take off the blanket on top and let people blossom. And remember, when you're a leader, you've got to promote the concept of failure to a degree. If everybody is afraid to fail, they'll never try anything new. And if they go out of line a little bit by trying to do something different and new, and you slap them on the hand, they're going to regress back into a kind of a catatonic state and say, I ain't doing it anymore. You've got to release, and you've got to be able to tolerate that sense of disruption and come up with new ideas. In the world we're in today, with the demographic changes, the technology changes, the customer requirement changes, it is all different. Any rule that was made 5 years ago, 10 years ago, is, by its very nature, probably irrelevant. But you've got the latent talent that it needs to be allowed to blossom. That's what's important. Young people, they're a source of extraordinary ideas. We, the baby boomers, have to listen, appreciate, modify it based upon experience, but don't kill it.
Great. Thank you very much, Michael.